Welcome, everyone. Okay, let's get started. Okay, good afternoon, everyone. Welcome to our Week 3 Duke-CZI Initiative Neurodegeneration Challenge Bench to Bedside Virtual Speaker Series. We are a group of 3 trainees at Duke University studying neurodegenerative disorders in Dr. Aula Spada and Dr. Chala Irgu laboratories. And I'm Shi Wang, and my colleagues Pia and Luke are also here today. Thanks to the sponsorship of the Trent Zuckerberg Initiative Community Grant, we have this great opportunity to build a network among academic scientists, biotech researchers, patients, and clinicians who are working in the field of neurodegeneration in the Research Triangle Park in North Carolina. And we believe that the collaboration among these groups is the key to cure neurodegenerative disorders. In order to build this community, we have brought together experts from each of these groups to share their experiences, challenges, and ideas. And we hope this speaker series will bring the community together and connect us for future collaborations. So before I introduce Dr. Sneha Mantri, I want to go over some logistics. After Dr. Mantri's talk, we will have an open Q&A session, followed by Zoom breakout group discussions to network and discuss ideas. And I also want to encourage you to join our Slack channel, and please feel free to introduce yourself, share your experiences on our Slack channel. Without further ado, I would like to introduce today's keynote speaker, Dr. Sneha Mantri. Dr. Mantri is a neurologist who cares for patients with Parkinson's disease and other movement disorders. She is interested in the imaginative formation of physicians. In particular, she uses creative writing to improve physicians' understanding of patient experience and to mitigate physicians' burnout. Her narrative medicine projects have been presented at numerous national and international conferences, such as the Innovations in Medical Education Conference and the annual meeting of the American Academy of Neurology. As a movement disorder specialist, Dr. Mantri is also involved in patient-physician communication initiatives sponsored by Michael J. Fox Foundation and the Parkinson's Foundation. She was a founding editor of the Intima, a journal of narrative medicine, and a former writer of Synapses. She is currently working on a historical novel on the eugenics movement of the early 20th century. So everyone, please join me in welcoming Dr. Sneha Mantri. And Dr. Mantri, the stage is now all yours.
Great. Thank you for that wonderful introduction. I'm actually going to be talking about something a little bit different from narrative medicine today and kind of putting on my clinician hat. Let me share my screen. Can you guys all see the PowerPoint? Great. As was mentioned, one of my primary roles here at Duke is as a clinician in the Movement Disorders Center at Maureen Road. And so I really wanted to focus on sort of this concept of bench to bedside, but also clinic to community, and what we can do to help people live well with Parkinson's disease kind of across the spectrum. This is kind of a brief overview of what I mean by that, sort of moving from concepts in bench science through to bedside, medicine with individual patients, ways that we can reorient or reformat clinical care, and then out into the community, what types of changes do we need to induce or see in order to, again, help people live well with Parkinson's. And then we'll wrap up as usual with certain breakout rooms and some interesting questions to try to spark some conversation along all those lines. And I want to look at all of these, this continuum within one particular disease strategy or disease treatment strategy, and that's exercise. And what do we know about exercise across that continuum? So just to start off with the bench science, a brief disclaimer that I'm not a bench scientist, and so please forgive me if I misspeak at all in this portion of the presentation. But we do know that exercise has a lot of different impacts at the level of the synapse, at a really kind of molecular level. And this is kind of a busy diagram, but essentially what I want to convey here is that both voluntary and forced exercise leads to upregulation and release of various trophic factors, such as brain-derived neurotrophic factor and glial-derived neurotrophic factor, both of which are crucially important for survival of individual neurons in the striatum and the nigra, maintaining axonal integrity and neuroplasticity. And so that has a lot of downstream impacts in terms of synaptic release of dopamine, in terms of suppression of apoptosis and angiogenesis to help to promote maintenance, again, of both the neurons and the glia that we know are so important in affecting disease progression in Parkinson's. And one of the ways that we really know this or have a sense of this, that exercise is protective against dopaminergic changes in Parkinson's, really comes from mouse models of Parkinson's initially, between mice that are exercised versus mice that are sedentary. And there's a lot of work in this field. This is just one example of a look at what happens between control mice. Can you all see my cursor? Control mice versus control mice that are exercised. You can see the sort of a pretty similar uptake of tyrosine hydroxylase. Mice that have Parkinson's or mouse Parkinsonism have a significant decrease in their tyrosine hydroxylase uptake compared to the control mice. And mice that are exercised, again, that sort of mitigates that dopaminergic loss in that group. And you can see that in the striatum, you can see that in the substantia nigra as well. And you can also see that in a more quantitative sense when you look at optical density of tyrosine hydroxylase, again, in the striatum and the substantia nigra. The Parkinson's mice have substantially less tyrosine hydroxylase uptake in the compared to controls, but exercise mitigates that somewhat, although incompletely. We also know that, or we have a sense that exercise may be protective from some human epidemiology studies. This is just one example of many. This group looked at a number of patients who were recently diagnosed with Parkinson's disease and characterized their pre-morbid exercise habits and sort of divided them into three groups. There was a sedentary group in red, the minimally active group in blue, and then a regularly active group in green. And what you can see is that, there's a lot of scatter in this plot. But in general, for individuals who were sedentary in the red, as their striatal dopamine uptake decreased, their motor UPDRS score, so a kind of clinical measure of severity of motor impairment, increased significantly. So in a sort of linear fashion. Whereas the groups that were more active, both the minimally active and the regularly active group, had a much flatter curve, if you will, promoting this idea of motor reserve in the same way we think of cognitive reserve. So in a sense, folks who are more active and exercise more may be protected against the loss of dopamine that we know occurs in Parkinson's disease. So how does that translate into how we think about and talk about exercise really at the bedside in terms of activity? This is a slide that was put together by one of my colleagues and mentors, Jim Morley, and I really like it because it emphasizes a few different things. One, that there's multiple different forms of exercise, from aerobic exercise to strengthening, balance exercises, flexibility exercises, and all of those areas, all of those domains are critically important for folks with Parkinson's. The other thing that this diagram kind of emphasizes is that at every stage of the disease, from sort of your unilateral initial diagnosis or early diagnosis in Hoehn-Yahr stage 1, all the way through to increasing levels of physical impairment, there are still things that an individual can do to help, again, maintain strength, maintain flexibility, at each stage of the disease. And one thing that we find just on a clinical level is that folks who are more active, particularly in the early stages of disease, tend to progress more slowly through this disease continuum, sort of going back to the idea of motor reserve and neuroprotection from physical activity and exercise. There's lots of ways that I personally talk about exercise with my patients. I'll often show them that diagram or discuss that sort of diagram with them. There's also ways to be a little bit more, I suppose, objective about it. There are groups that are looking at exercise prescriptions, actually a physical prescription that you would hand to somebody and check off, this many minutes of aerobic versus balance versus strength and so on. One study out of New Zealand a few years ago found that a year's worth of exercise prescriptions cost less than 100 New Zealand dollars. It was about, I think, 65 US dollars, and had significant cost savings in terms of poor outcomes, in terms of fall risk, in terms of hospitalizations and ER visits, and so forth. So very cost effective. There's also more recently apps and technology that we can use to sort of fill that prescription style or those reminders to patients as well. One of the big challenges with both exercise prescriptions, with apps, and with the sort of one-on-one counseling, as I mentioned, is that it can be very time consuming. And so it can be hard to sort of get to, if you will, in the framework of a 30 or even a 60-minute clinical visit. But it really does sort of pay off in terms of good outcomes for patients down the road. There are, as you might imagine, a lot of different barriers to that, to actually exercising. This is a qualitative study that I did a few years ago, looking at patient-reported determinants of exercise. And it sort of broke out. We asked patients what makes it easier and what makes it harder for you to exercise. And it broke out into kind of three big groups. The first one was the patient's own individual health. There are other comorbidities. Fear of falling was a really big one. Lack of motivation was a big challenge for many people. On the plus side, a desire to sort of maintain independence and remain in their home or in the community was a huge motivator for people who were exercising. There was a social aspect to exercise that was, again, very important for, I think, the vast majority of patients that we surveyed, whether that's exercise partners or group programs such as Rock Steady Boxing and other Parkinson's specific programs. Sometimes it was actually, on the flip side, a little bit challenging for some patients who were very involved in either the Parkinson's community or a non-Parkinson's community to make time for exercise. And so having these classes or these exercise partners can kind of help keep somebody on the wagon, if you will. And then lastly, more infrastructural or environmental issues, things like the weather, people's neighborhood, and whether there was a safe space for them to walk, whether they had access to a gym or to exercise classes. And I'll be coming back to some of this environmental stuff a little bit later in the talk. But I mean, this is, I think, one area that particularly now in the situation we all find ourselves in with the coronavirus pandemic, a lot of the typical spaces where people would exercise and would be active are less available to them than they were, at the time that I did this survey, for instance. And so I think we can potentially start to have to think a little bit more creatively about how we might address each of these patient-reported determinants of exercise as we start to hopefully design or think about some alternative strategies. And that sort of brings me to my third point in the continuum. So we've talked about bench medicine, we've talked about the bedside medicine, but how can we kind of reframe our clinical care of patients with Parkinson's away from this one-on-one strategy? because as I've alluded to, there are a lot of challenges to the traditional bedside medicine model for folks with Parkinson's. It's a very complex disease involving multiple specialties and multiple issues, and it can be very challenging to address all of those in the allotted framework that we have. For instance, referrals to rehab services such as physical, occupational, and speech therapies, also cognitive testing, are part of quality metrics from the American Academy of Neurology. And yet a substantial number of people with PD are not receiving those services. If you look at this graph on the left, the map on the left in blue, this was looking at Medicare beneficiaries with Parkinson's who had received physical or occupational therapy within the first 3 years after their Parkinson's diagnosis. And what you can see, we're here in North Carolina in this kind of medium blue color. And that's the middle tertile. So not terrible, not great. When you look at the actual numbers, it's really not great. It's only about 1 in 4 people with Parkinson's really get into PT or OT early in the course of their disease. And even the areas of the country that are doing quote unquote well in the top tertile, it's still only about less than 1 in 3. So really not anywhere near where we would want it to be. And interestingly, this didn't match up with areas where there was a low supply of rehab therapy providers based on kind of Medicare data sets. So there's other stuff going on here that I think requires a little bit more investigation. We looked at this in another way as well, looking at prescribing habits, just as a marker for how complex a person's care might be. So this was looking at co-prescription, this graph here in red, looking at co-prescription of an anticholinergic medication, as well as a cholinesterase inhibitor. So 2 medications that are directly contraindicated to each other. Work in exactly opposite ways in the brain. And what we found is that potentially inappropriate prescribing was rampant across the country. For the Durham area, specifically for the Durham Health Referral Region, this was 42.9%. This is 2017 data. So a few years old, but again, not anywhere near where we would want it to be. And that varies again across the country. But there's certainly, I think, a lot of work to be done in both of these aspects. And specifically, when we dug a little bit deeper in both the PT/OT referrals as well as the prescribing habits, what we found is that one of the big drivers of this was not so much where you were located, but race and ethnicity. So one of the concerns is that relying on this one-to-one counseling in the office may actually inadvertently magnify some healthcare disparities just because of unconscious bias and overall access to services. So essentially, the standard model isn't necessarily working for all people. And how can we make this better and more effective overall? We know the standard of care is sort of what I call a leaky pipeline, and there's lots of different spots that are leaky across the way, from the referral to a movement disorder specialist all the way to actually improving outcomes for the patient. And so trying to think about different ways that we can start to plug some of these leaks and help people get the care that they need. This is one way that we've tried to address that here at Duke. We've developed a comprehensive care clinic for people with Parkinson's. This was presented at the Movement Disorders virtual meeting earlier this fall. But essentially what we've done is, because of that leaky pipeline and the difficulties with referrals and access, we've created a one-day, one-stop shop model for folks with Parkinson's, where traditionally, when before COVID, people would come in the morning, and through the morning they would meet with physical, occupational, speech therapy, social work, pharmacy, and our physician's assistant. There would be an interdisciplinary team meeting at 12:15. And then at 1 o'clock, the patient meets with their movement disorder specialist to come up with a sort of individualized treatment plan. And this is what we found in our sort of initial iteration of this clinic. It was very well received by most people. You can see in the map here, we're located right here where this yellow dot is in Durham. And then we really had reach across the state from the mountains all the way to the ocean, predominantly from our sort of local region in the triangle, but really kind of stretching across the state. We had several out-of-state visitors as well to our clinic. And then it was, as I mentioned, very well received by the vast majority of participants on the clinic feedback survey. We did have some patients sort of cancel and no-show, and our social work intern called them to figure out what the reasons were. The most common was because they were concerned about the very long appointment time, or because of trouble with weather or other illnesses. Looking at the demographics of who got into this benchmark clinic, the median age was pretty similar to our overall clinic population. One thing that I think this does highlight, though, is this, again, race and ethnicity disparity, where the vast majority of participants were Caucasian, and we were really sort of undersampling or under-reaching the African American and Asian communities. And so we're trying to think of ways to help broaden that reach, particularly now in the era of COVID, where the clinic has moved to a virtual format as of this past spring. And we're hoping to be able to, again, expand our access even further as time goes on. So stay tuned for that. And I'm very excited to hear about if anybody has any suggestions in the Q&A or in the breakout rooms about how we can continue to improve this care model. And then the last thing I want to talk about before we break out into our breakout sessions is thinking even more broadly and trying to think about community level changes and what types of infrastructure we need to help folks with Parkinson's. This study was not Parkinson's specific, I want to be clear, but it was a really nice look at walking habits of older adults and inequity. So this was looking at older adults in Birmingham in the UK. You can see where that's located on this map of the UK. And what they did was identify 4 high deprivation neighborhoods in the city, which are in gray here, mostly kind of in the center of the city, and then 4 low deprivation neighborhoods, all of which were located in kind of one corner of the city. This was based on a standardized index of multiple deprivations that's used by the NHS to help characterize neighborhood inequity. And what they did was sort of assess the access to green space, things like parks or gardens or outdoor walking areas in each of those neighborhoods, and then collected the number of minutes per day that an individual was walking over the course of 1 week using a GPS watch. So really kind of tracking outdoor walking as opposed to kind of walking around your house. And what they found was that the 2 groups, the low and the high deprivation areas, were pretty well matched on a number of different characteristics. The biggest differences were that ethnicity was more commonly, was more diverse in the high deprivation areas. And then educational attainment, there was also a bit of a difference in that the GCSE is sort of the British equivalent of a high school diploma. And so folks in the high deprivation areas were less likely to have completed essentially a high school diploma, so lower education status. And what they found was that between the high and low deprivation areas, there was a significant difference in minutes of outdoor walking, about 5 minutes per day between high and low deprivation, which doesn't sound like a lot when you say 5 minutes a day, but 5 minutes a day really adds up. And 5 minutes a day can be the difference between meeting your American Heart Association guidelines of exercise habits versus not. And so that's, I think, a really important indicator that things like infrastructure can really, really matter. When they looked at what were really the drivers of who was walking versus who wasn't, the biggest one was not any of these kind of demographic characteristics. It was how close were you to a park that was at least 1 acre in size. And that was the biggest sort of overall driver of whether or not people were actually getting exercise outdoors. And so, taking it back to our area, when you look on, Google Maps, for instance, the triangle looks fantastic for outdoor recreation. We've got Falls Lake, we've got Jordan Lake, we've got a whole bunch of different parks in our area, which is, I think, really important. But when you look at it in a slightly different way, when you look at walk scores, what you see is that people are not, the majority of people in our area are living in car dependent zones. So what you can see with this walk score is, for instance, downtown Durham, there's kind of this cluster of walkability. Same with downtown Chapel Hill. Downtown Raleigh's is a little bit larger. But there's these really large, areas where people are living in, suburban style neighborhoods without access to safe walking spaces, things like sidewalks and trails and whatnot within the space that they're living. And so I think, when I looked at walkscore.com, there's no city in North Carolina that breaks 50%. The best was actually Boone at 49 out of a possible 100. And so I think this really kind of illustrates potentially the uphill battle that we face in our area in order to promote exercise and walkability for our patients. And so, one thing that I think is really kind of intriguing in this whole exercise and walkability metric is, how do we really measure exercise and activity in the real world setting? And there's a few different ways you can do that. This is one example of a scale that's called the physical activity scale in the elderly. It's a patient-reported outcome scale of how much time they spent in, a variety of activities over the past week. One thing I really like about it is you can break out leisure versus household activity. And you can specifically sort of pull out things like moderate sport, vigorous sport, and strength and endurance, because when we say exercise, that's really what we're talking about, this kind of more intensive activity. And this scale's been validated in older adults against a number of different objective metrics, including things like oxygen consumption and fat mass, and seems to be valid. More recently, there's also fitness trackers that can provide a really objective measure of exercise and activity in real life by looking at things like step counts and so on, and minutes of activity. So you're not necessarily relying on somebody's, recall of their activities over the last week. So I think this is a really kind of exciting way to start to think about how we can be a little bit more detailed about how much people are exercising and walking. And specifically with the fitness trackers, I think this is a really great way that we can start to get things like exercise networks and social networks involved. This is some data, again, not Parkinson specific, I should be clear, out of Australia, looking at 1.1 million users of a social network for exercise, who collectively over the course of 5 years ran 350 million kilometers. So just for context, that's more than the distance to the sun and back among these individuals. And what they found was that when you look at a variety of exercise factors, say, for instance, distance that an individual runs, if I were to run 1 kilometer, my first degree friends would run an additional maybe 350 meters. So sort of that motivator to beat your first degree friends. And then the second degree friends run a little bit less than that. And third degree runs a little bit less than that. So this social influence coefficient, the beta of how closely people were linked, sort of waned with the distance or the size of the nodes, as well as over time. But it held true for distance run, for pace, for duration, and for calories burned in a really kind of clearly linear way. And the overall multivariate model was fairly robust in explaining a large percentage of the variance between people's running habits. So I think, again, this wasn't Parkinson specific, but I think it does sort of provide some clues of how we might help with things like motivation by creating these and leveraging these communities of runners, but also communities of folks with Parkinson's to help motivate people.
Hi, okay, cool. Dr. Mantri, yeah. Just about to say that like we are at this, like we have 1 more minute left for your
time. Perfect. Yeah. So that's my last slide. That's what I wanted to leave you guys with, is how can we leverage community partnerships? How can we ensure equitable representation, and what other types of strategies can we use to help provide motivation for some of these changes? And that's it.
Cool. Thank you so much, Dr. Mantri. This is a great talk. And so now it's we will go into our Q&A session. And if you have any question, please feel free to write it on the chat, and then I can read it out for you. And or you can also write on our Slack channel, or you can also ask your question. Just unmute yourself and ask your question yourself. And so I can ask the first question. Actually, I was really inspired by your presentation. One question I have is, you mentioned how important the exercise is for Parkinson's disease patients. However, recently I was reading some literature and understanding apathy is a core symptoms in PD patients. So at certain stage, patients with Parkinson's disease, they start to lose motivations of doing the things they used to be interested in. I was wondering, you know, exercise does require a lot of motivations. You need to get up and to get out. And do you have any, you know, advice or strategies, and then what the patients can do to, you know, keep the motivation up, and then try to help themselves out?
Yeah, no, that's very true. I mean, because exercise has such a big impact on, or dopamine levels have such a big impact on motivation and apathy. And so it is a big challenge for folks with Parkinson's. One thing that, again, in that patient-reported determinants of exercise study we did that really sort of came to the fore is that one of the biggest things that helps people with or without Parkinson's, but I think particularly for folks with Parkinson's, is having somebody else sort of to be your cheerleader and to be your exercise partner, or to be in an exercise group that can help to sort of boost that and keep people going even when they don't feel motivated necessarily to restart.
Okay.
I have a quick question.
Mm-hmm.
Dr. Mantri, great presentation. As far as the bench evaluation goes by the multidisciplinary team, those of us who have young onset of Parkinson's disease do not have Medicare or supplemental insurance for this coverage. And that is a policy issue, I understand. But a lot of us in our 30s and 40s who've been diagnosed with the disease find it extremely challenging to even find coverage, which really doesn't help in the disease or the stress level of the disease, because there's so much to be taken care of on the disease itself.
Absolutely. No, I absolutely agree. I think the challenges of insurance navigation for folks with Parkinson's, particularly, as you said, for folks with young onset Parkinson's who may not qualify for Medicare or some of the other governmental insurances, I think is a real challenge to try to get around, because private or commercial insurances can be so variable in how much coverage they provide for things like PT or speech therapy. And so it is, you're absolutely right that it's a big barrier to receiving care for folks.
And I'll just take this one step further. And once again, it's a policy issue. So rocksteady boxing has been scientifically proven very effective for Parkinson's disease. And none of the health insurance companies that I have researched even covers it.
I know I'm totally there with you. Rocksteady and a lot of other programs that are sort of, for whatever reason, not classified as physical therapy can be really hard to get covered by insurance, even though it's as effective as PT and can be so beneficial for people. So yeah, I agree. I mean, this is, as you said, a policy issue. And, you know, I'm not sure whether it would be policy at the level of each individual company or policy at a more global level that would sort of help to force or enforce insurance companies to cover this type of stuff. Because we know that it's effective and we know that it works and people enjoy it. And so it's really, I'm right there with you. It's frustrating when people can't get things that they need.
And Sneha, I do like the prescription sheet that you showed earlier on. I mean, that's an indication right there that is prescribed by a physician or neurologist. So there must be a reason behind it.
Yep.
For that prescription.
Yeah, the prescriptions are pretty great. One group that has really been sort of pushing that, it's called exercisesmedicine. I can't remember if it's .org or .com, but they're not Parkinson specific, but for any chronic disease. And they have these exercise prescriptions that you can literally print out and check off and hand to people. It can be helpful.
Thank you.
Okay, we have 1 minute before our breakout session, but Cassie Ross has a question. Cassie, would you like to ask yourself or I can ask for you? I think it's also a question like a lot of people may be interested.
I was asking about I forget what you call them, Dr. Mantri, but the clinics where you meet with the PT person and the OT person. I was wondering if those, I was signed up for one, but then it never happened because of COVID. So I wondered if they're going to be restarted at some point.
So we've restarted them in a virtual format, at least for now, to try to minimize people's contact with multiple providers, but it's all being done over Zoom still. So let me, because I recognize your name, actually, let me, I will contact the coordinator. Her name is Rosa Valdiaste, and I will ask her if she can give you a call to get you back on the schedule, because we do, I think, have some openings coming up. So if you're interested in a virtual version of Benchmark,
do you feel like the virtual works well?
I think it does. I think specifically, you know, I've been talking a lot with our therapists to make sure that they feel that it works well for them, that they can get the information they need from folks. And they do feel that it's helpful. Certainly, I think, given that we don't have sort of an end date yet for when things can go back to normal with COVID, I would say that doing it virtually now makes sense. And if and when we can reopen in person, we'll convert everybody back to in person. But I'd rather have people on the schedule and get at least some level of care, even if it's not, you know, as detailed as the in person was.
Thank you.
So yeah.
Cool. Thank you so much, everyone. So let's start our breakout sessions.